So, we are very delighted to welcome our expert speaker for today's webinar. Before that, I'll introduce myself. My name is Vishaka. So, let's start with today's webinar. Today's webinar is with Dr. Apeksha Ubhare. Dr. Apeksha is a certified prosthetic and orthotist, widely recognized for her expertise in custom footwear and insoles. She is a passionate advocate for comfort, mobility, and data-driven foot care. With extensive clinical experience, Dr. Apeksha has personally consulted over 1,000 patients, providing personalized solutions for a range of conditions, including flat foot, plantar fasciitis, diabetic foot ulcers, and more. Her patient-centric approach and focus on biomechanics have helped individuals regain mobility and reduce foot-related discomfort through innovative and evidence-based interventions. We are excited to have her share her insights, case experiences, and practical applications of plantar pressure analysis in today's session. So please join me in welcoming Dr. Apeksha Ubhare.
Thank you, Vishaka, for the warm welcome. Let's start with today's webinar. Good evening, everyone. I'm Dr. Apeksha, a certified orthotist and insole specialist. I'm truly honored here with a wide range of audience, PNOs, physiotherapists, and clinicians. As we know, footwear isn't a specialty care anymore. Today, we are diving into data, particularly plantar pressure mapping, how it is transforming the way we assist the patients. And this is not just a tech talk. It's more about clinical outcomes, clinical data, and how we see the patient stories and how we can deliver smart intervention. Let's start with objective of the webinar. So, plantar pressure analysis, how it can aid you to the evidence-based decisions, use the data to design specific patient-specific custom insoles and improve precision and effectiveness of a insoles prescription. Let's start simple. Why does footwear matters? So, stat shows 70% of the patient suffers from foot-related problems. We must have seen it. Knee pain, heel pain, back pain, all of it in our OPD. So poor footwear not just lead to the foot pain, but it also go to the your upper body and gives you performance issue as well. So poor footwear is not just a fashion issue, it's a clinical risk. Now, what we have done to make a insoles? Traditionally, we have started with foam box impression, plaster casting, visual gait observation, ink and carbon paper footprints, trial and error adjustment. As you all be knowing, foam boxes, delicate to handle, we have to get a static data which is prone to error. Plaster casting, it is a time consuming and it is a manual. It needs a highly clinical skill. Visual gait observation, you have to go to see the patient the way they walk. You have to sit on your knees and check the visual gait data. It is too subjective. It can change from me, you, and anybody. We can take ink and carbon paper footprints. It's crude and static analysis. Again, highly depend on how the patient stands, how you make them stand. Again, the trial and error adjustment is depends on the feedback, and you can use Harris mats for that matter. But it depends on the patient feedback. It varies from people to people. Now, we have relied on this all our lives. It is 90s tools and they have served us. But we are in 2025. Are they really helping us? They come with the limitation of they are subjective, non-standardized. We cannot track improvements. Do we? They come with a poor fit first accuracy. We cannot see the dynamic data. All these things we are doing with the static analysis more. Next, it is high dependence on the clinical skill. Let me show you the science of today's. The science of plantar pressure mapping. Here, the plantar pressure plate having thousands of sensors and collecting a real-time data, dynamic pressure data, while the patient stands and walk. It identifies peak pressure zones and asymmetries in a real time and in quick motion. Quantifiable data metrics for a integrity of insoles and footwear design. Visual reports that improves patients' communication and compliance. Here you can benefit your patient as well, your clinical practice as well. Move on to the benefits of clinical practice in the plantar pressure system. It identifies the risk zone. Now, as we know, let's come to the real case. You have a diabetic patient. He visited you. Now he doesn't have any skin condition. It doesn't showing any corn calluses or ulceration. Asymmetrical data in a gait. Now you can have this a data backed decision as well to improve his treatment plan. You can educate the patient about his coming future things, his prognosis as well. You can detect ulceration earlier or his foot condition beforehand. You can personalize his insole intervention with the help of plantar pressure in your clinical practice. Any question till now? Okay, let's move on. So, how we can use evidence-based insoles in a workflow, in our workflow? We can start with patient foot assessment and gait observation, as we usually do. You can assess the patient's feet and observe his gait. And now you can take a plantar pressure data and analyze his load and weight distribution. After you're done with the weight distribution and their after analyzing the weight distribution and load, you can start designing their insoles and start with the fabrication of the same. Now, after the fabrication of the insoles, you can start with the fitment and monitoring of the patient's condition. This can be done after doing a plantar pressure data, and post fitment you can also check the results of the same using the plantar pressure data post the treatment. Let's move on. Here is a one case of plantar pressure data and his clinical relevance. Here we can see is a bipedal test done on the patient. The bipedal test before intervention, you can see clearly here bilateral weight distribution of left side is 44% and on the right side is 56%. What we can understand here, this patient is loading more on the right side. So what will be the possibility of it? He may be having a heel pain or right side compensation. He is having maybe left side issue. So much more possibility you can gain from this. Next is average pressure. You can see his right average pressure is 37.77 kilopascal and his left side average pressure is 34.91 kilopascal. What we can see is the average pressure is usually high on the right side, showing it's more than a normal range. Maximum pressure here on the right side 175 kilopascal and on the left side is 144 kilopascal. So it's a significantly higher and can show the risk of different things. Now you can also see in bipedal weight distribution of the hind foot and forefoot of the left side it's 78% and on the forefoot it's 22. So the patient is loading more on the hind foot and he is having rear foot posture. On right side, he's showing 75% of the hind foot distribution and on the right forefoot 25%. Again, the same weight distribution as the left side, rear foot posture. After the intervention of the insoles, the patient shows significant changes. Now, he is showing bilateral weight distribution on the right side is 52%, on the left side is 48. So as we can clearly see, the numbers are telling us his weight distribution is changed. And the average pressure you also can see is into the under control, into the safe zone, which is 23.10% on the right and on the left it is 20.8 kilopascal. So after changing his distribution with the insoles, he can significantly change his pressure as well. Now the maximum pressure, we can see the values into under the 100 number. The right side value of maximum pressure after the intervention is 59.54 kilopascal and on the left side is 73.14 kilopascal. Now the weight distribution of the forefoot and hind foot. On the left side, it is significantly changed. It's 61 on the hind foot and the forefoot is 39, which is close to normal. Ideally, we should be bearing 60% on our hind foot and 40 on our forefoot. It's also changed on the right side. On the right side, the hind foot weight distribution is 63% and on the forefoot, it is 37%. Again, close to the normal. So here we can say without this data, we must be guessing it. Ki actually what is happening? Is it the change happened? It doesn't happen. This number tells us the real story. Does your insoles working for him or not? Let's move on to the dynamic data of this case. Now, here we can see in before case, the patient showing stance time of 0.89 seconds on the left side, and on the right side, it is showing 0.82 seconds, which is significantly higher, and which is the patient is taking time to push off. Also, the index is showing us the patient is having fallen arches and collapsed arches. Now, the foot progression angle. On the left side, the patient is showing 10.11, and on the right side, it is showing 3.72, which is again a toe off is dynamically changes, and his peak pressure is significantly higher. On the left side, it is 324 kilopascal, and on the right side is 347 pascal. Imagine having this much pressure under the feet, and the patient is walking with the pain. Now, after the intervention, the changes we can clearly see here. The arch index is improving. Patient is showing a normal gait line as well. Here, the midfoot distribution is getting to normal, and the average pressure is also changing. The average pressure is coming to normal range, and the peak pressure is significantly changes on the right side, which is 178 kilopascal, reducing the risk of any ulceration, corn, calluses, or hardening. Now, okay, any questions till now on the case?
Dr. Apeksha, we have one
Apeksha,
question.
Yeah,
nice explanation. I also have one question, but after your explanation, I will ask the question. Not on this case. I have another case regarding that.
okay,
I would like to discuss.
okay. I heard you. Vishaka, do we have any question in chats?
Yes, we have one question.
Hmm.
What is the time period for this particular case?
After the intervention, it takes 3 to 4 months to show this much results. Okay. Shall we move on? Okay. So, the objective effects of this intervention shows that it reduces the peak loading, it offers the compensation asymmetry to be a symmetry, and also the pressure spread is distributed. This is especially critical in patient and to show them the outcomes as well, and to enhance their lifestyle as well. Let's move on to the real case studies now. So we had a case study of one diabetic patient which is a 73 years old and having diabetic mellitus, peripheral neuropathy, and also had an orthopedic surgery done on his right side, total knee transplant. His current condition showing left side second stage sarcode foot with an unhealed midfoot wound. He has on the right side, he had a con, and also he has a neuropathy, so loss of sensation in both the feet. Now, what assessment we did? We check his foot condition. On the right side, he has a con and a plantar and on a plantar surface, and on a left foot, he had unhealed midfoot ulceration. As we know in sarcode, the structure of the midfoot collapses and create a load on the foot surface. In the structural anatomy, we see in the sarcode foot condition and we addresses it. Next, he has a loss of sensation on a joint range of motion. He had, due to his diabetic condition and sarcode condition, he had a restricted movement in the left ankle. In manual muscle test, we understood his ankle strength was not that much enough and it has a reduced strength. This is his wound and his plantar pressure report. We can see his wet distribution is 53.75% on the left, and on the right side it is 46.25%. Why it is so? The first thing he had done with the right side TKR, so he is more prone to lean on his left side to compensate his left side on the right side. Now his forefoot and hindfoot distribution, his left side forefoot distribution is 8.09% and his hindfoot is 91.9. Why? because he having a ulceration, which is because of the bed bearing. When he had a TKR, he was facing a lot of issue to compensate his body, and he also got into LLD stage because of the limb lengthening. So his bed distribution on the left changes completely. Any questions? On the right side, his forefoot weight distribution is 22 and his hindfoot weight distribution is 77%, which is also hampering his leaning more on his heel side. His maximum pressure on the left is 253% and on the right side it is 109 kilopascal. We can clearly see his wound here, which is protruding and is a ulceration. Let's move on to what treatment we planned for him. So he was homebound patient and he wanted to use a footwear at home. So we gave him a custom diabetic footwear personalized for him, designed to reduce his injury risk and support foot structure. In his footbed modification, we added a poron material. You must have heard about this material, which is diabetic friendly and offload the midfoot ulceration. We also added 2.5 centimeter heel lift for his leg length discrepancy. On his right foot, we added a poron padding under his callus as well to use it to reduce the friction because it absorbs the shear pressures. And added medial arch support and metatarsal pad for a pressure relief. Now, after using this footwear for more than 6 to 7 months and continuous utilization of the same, we can see the result. You can see clearly here on the left side, the scar tissue visible at a prior ulcer site. Sign of healing you can clearly see here. Improve skin texture and no open wounds. Decrease inflammation in the midfoot, which causes decreased inflammation in the midfoot. On the right side here, he had a callus, but now it is control and no hardening as such. Overall skin integrity looks maintained. Patient returned to his normal life, his wound is no more, his diabetes is controlled, and he can walk normally. This is the outcome of this case and personalized intervention. Now, let's move on to the case which we see on day-to-day basis. Anybody have any doubts in this case or anybody wants to ask any question into this case?
Dr. Apeksha, we have some questions in chat box.
Yeah, please go ahead.
So we have a question from Dr. Cash that how do in-shoe sensors compare with pressure platforms? What is the validity and reliability of the system you use for this case?
So in-shoe sensors are definitely a thing, but it depends on the brand to brand again. The validity will be changing. Plantar pressure system shows a wide range of data to you as compared to in-shoe sensors. Any more questions?
We have one more question. What type of arch index is used?
It's 0.22 to 0.25 is a normal arch range, and beyond that, that is 0.25, 26 to 0 point above that, you can use as a flat pit collapse arches and low arches. Below 0.22, it's a high arches. We use that range.
We have one more question.
Okay.
What is the shore value of the poron?
So we used in between of 15 to 20 and A shore value. So shall we move on to the next case?
Yes, ma'am.
So this is the case which we must have seen on the day-to-day basis, an athlete with a heel pain. So we have one case, a male with a age 36 having a severe heel pain and foot pain during standing and walking. He had a fat pad atrophy and also had a hung deformity, also known as a posterior calcaneal spur. He had a lifestyle of highly active lifestyle, plays cricket, badminton, and tennis 2-3 times a week. So, as he was athlete, he has a full ankle mobility, good muscle strength, but due to impact, he had a heel pain and also had a fat atrophy on the heel pad. So, this is his data on a bipedal test. You can see his left forefoot showing 32% of the load of his body load, and hind foot shows 68% of the body load. And on the right side, it shows forefoot shows 35% and hind foot shows 65% body load. So he's more leaning on his left hind foot. Now, on dynamic side, high pressure on the forefoot region, we can clearly see here on the both the feet during the particularly in the feet and under the metatarsal heads. In the midfoot, the arches appear relatively unloaded and suggest normal to high arches. The curve is, we can clearly see the curve, and the heel contact is moderate and similar. Now, we have given him custom insoles with shock absorbing material for high impact and support and reduce strain. We also give him modification with the heel cushioning, moderate arch, and metatarsal pads to offload the method load, and 5 heel raise to offload the heel loading in static. What we got in the outcome after 1 month? So initially, as we know, after using custom insoles, patient may face the issue in adapting to it. So there is a breaking period we should always give to the patient and regime to use it. They can start from 10 to 15 minutes, depends on their pace, and they can increase their times by 1 hour or 2 hours in a day. Initially, he was feeling discomfort, but after gradual using, he was comfortable with the insoles and he's returned to his high active lifestyle. The clinical insight into it, after smart cushioning and gradual adaptation to the insole, high active patient also can return to his sporty lifestyle. Any doubts in this case or any questions? So we are using arch height, not we are using arch height index, not arch rigidity index. So total length of foot area, total foot area. So I have one question: which evidence is provided for the values of arch index? So we have used the evidence of total foot area divided by the midfoot area for the arch index. We can have the most of the research paper are also available for the same. What was the material used for what was the material used for the cushioning and padding? It can derive varied from EVA, Poron. You can also go from silicone based foams also. Can the Poron material replace by an enzymatic which is locally available? Definitely you can go for anti-shear EVA, which is locally available instead of Poron. So why anti-shear EVA? So anti-shear EVA also plays a role like a poron, which absorb the shear forces when patient walks. They move this way. So this shear forces can be absorbed by anti-shear EVA. So you can use the local material as anti-shear EVA. Any other question? Yeah. So this is how we can improve the active lifestyle patient as well into their custom insole journey after using, after understanding plantar pressure and their results. So what is the clinical relevance of a pressure mapping? It supports multidisciplinary team, evidence-based alignment, useful in diabetic care, rehab, mobility, and it's a measurable inputs. For example, in PNOs, PNO can opt for this plantar pressure system to integrate into custom insole designing, its fabrication, and understand patient's prognosis. In physios, they can opt this for gait correction rehab. In physicians, operative alignment and offloading. So we all are part of the biomechanic loop. So let's close it together with the pressure map. Uh, any questions?
Good evening,
Hello.
Apeksha.
Good evening, ma'am.
Yeah, am I audible?
Yes, ma'am, you are audible.
Yes. Recently, yesterday only, I had a phone call from my friend. She is 48 years old, and she is
Hmm.
now going through the because of some during her delivery,
Hmm.
while she was giving birth, the anesthesia which was given was
Hmm.
wrongly given, and because
Hmm.
of that anesthesia,
Hmm.
her one nerve is damaged, and
Hmm.
now she is recently going through the neuropathy, not neuropathy.
Okay.
I have seen her the this thing MRI reports also,
Hmm.
and she is having numbness also. She has a peroneal nerve not palsy, but peroneal nerve. There is a pressure on the peroneal nerve. So
Hmm.
she's slightly walking, though I have not physically assessed her, but this video which I have seen, in which she has a slight uh,
Hmm.
left side foot drop, and now she is
Okay.
developing a corn also.
Okay.
Okay, a heel corn. So might
Okay.
be the, yeah. So I just wanted to know whether it should be provided only insole, or along with that any other intervention is required.
So are you done with the question?
Only, sorry.
Are you done with the question?
Yeah, and one more, yeah. Only insole is sufficient, could be, or it will be required any other kind of orthosis or any with the only insoles. And these insoles, can these insoles only be fitted in the shoes also, or they can be used in the sandals as well, sandals or chappals? Yeah, I'm done with my question.
Okay. So as you said that she is due to her improper anesthesia, she is facing a neurological condition. You said that foot drop or something.
Yes, yes.
Okay, so as we know for foot drop, if it is not rigid, we can start with the proper shoe with which can cover till her ankle and supports it. You can also go for a AF if you want, and you can fix the insoles into it as well. Move on to you can assess her onto plantar pressure and understand how her loading is actually. Is she more leaning on the con side or offloading it, compensating on the other side? You can understand that as well. And not only insoles, sometimes patient may need a custom footwear as well. So it depends highly on what she requires. Like if she is not comfortable with wearing a shoes, the insoles will not be useful for her. Then you can go to a custom footwear making as well and do the modifications into footbed, which can be understand by plantar pressure report.
And are these custom footwear available with you?
Yeah, ma'am. But yes, ma'am.
Yes,
I
actually, I
can
could
connect you
let
for the
us.
same later.
Yes, yes, sure, sure.
Okay,
Thank you so much.
1 minute just. There are many, we have one more question. There are many different gait analysis machines or mats. How's your difference from others? As I believe there are a lot of other pointers or data that the gait analyzer can detect. Are there any other data that can be assessed and utilized while assessing the patient? Definitely, ma'am. There are many gait analysis machines and mats are available. It's not about us or something, but we have in Indian made machine. There are a lot of metrics which we all can work on. Right now, in a short session, I have showed you only the bipedal and dynamic data. You can vary it from a stance time to any of specific area zone pressure. You can also see it live in a live visualization as well. You can also see it into the balance assessment test as well. The patient balance can also be assessed from that. Uh, Again, can data, are there any other data that can be assessed? Yes, balance data you can also assess in the patient while using plantar pressure system. Uh, there is one more question. Is of superior or more relevant for arch index or exclusion arch index? I guess we should. It's depend on the system to system. Arch index, I guess, will be the best as it is having research backed thing as well.
Hi, I just wanted to understand what would be the optimal shore hardness for pour-on material or the grades of EVA or silicon that you would ideally recommend for these corrective insoles. Thank you.
So ideally, in Poron, if you say, see, you can go from grade A shore value, that is from 15 to 20. In EVA also, it depends on the case to case. If it is a diabetic case, you should be go from 15 to 20, and into the EVA you can go from 10 to 15, and also change the hardness or depend on the which segment you are using the EVA. If you are using into the heel region, you should go for the softer shore, and if you're using in the med pad, you can also change the shore to the 15 to 20 and 25 as well. For the silicone, I will not recommend the show value right now, because in the silicone, the show value is very limited. It's very lesser. It's less than a 10 show.
Got it. Thank you very much.
Thank you. So, I guess thank you all for your time and attention. If this session helped, let us know with the feedback. Uh, I believe the future of the foot care is not a personalized, it's a more data driven, and let's lead the change together. Thank you all.
Thank you, Apeksha. It was a
Thank
very nice,
you.
wonderful
Thank you.
session.
Thank you.
So big thank you all as well to all our participants for your engagement. We hope you have found today's session insightful and valuable. Thank you once again and have a wonderful evening ahead. Thank you.